Pulmonary embolism and pulmonary infarction. Dr. Muhammad Atif Qureshi, MBBS, FCPS. Associate Professor, Medicine. Pulmonary embolism, infarction. Embolism, impaction of a thrombus or foreign matter in the pulmonary vascular bed. Infarction, the pathological changes which develop in the lung as a result of pulmonary embolism. Pulmonary embolism, infarction. Thrombosis of peripheral veins, embolization of pulmonary arteries, and pulmonary infarction. Primary thrombosis in pulmonary arteries and veins, embolism. Thrombotic, non-thrombotic, fat, air, tumor, amniotic fluid. For drug abusers, risks decrease in blood flow below a certain critical level. Increase in coagulability of blood. Damage of the vessel wall. Risk factors bed rest postoperative. After severe blood loss and trauma. CCP. CHF. Varicose veins. Advancing age. Obesity. Postpartum. Malignancy. DM. Pneumonia. Debilitating diseases. 1. Polycythemia. Race, diet. Clinical features depends on size of the embolus and blood vessel included. State of the lung. Associated diseases. Massive P clinical setting elderly, possibly obese. Around the 10th day post-op. Calling for bedpan. Expiring suddenly or while in the act of defecation. Immediately fatal, 2/3 die in the first 2 hours. Massive P shock dyspnea apprehension tachycardia sweating chest pain. Faintness. Cyanosis. AF. Collapse. Pulmonary embolism. P is the most common preventable cause of death in hospitalized patients. 600,000 deaths/year. 80% of pulmonary emboli occur without prior warning signs or symptoms. 2/3 of deaths due to pulmonary emboli occur within 30 minutes of embolization. Death due to massive P is often immediate. Diagnosis can be difficult. Early treatment is highly effective. At least 90% of pulmonary emboli originate from major leg veins. Natural history of P. 40 to 50% of PTS with DVT develop P, often silent. P presents 3 to 7 days after DVT. Fatal within 1 hour after onset of respiratory symptoms in 10%. Shock/persistent hypotension in 5 to 10%, up to 50% of patients with RV dysfunction. Most fatalities occur in untreated PTS. Perfusion defects completely resolve in 75% of all patients, who survive. Clinical presentation. Dyspnea, tachypnea, or pleuritic chest pain most common. Pleuritic pain, distal emboli pulmonary infarction and pleural irritation. Isolated dyspnea of rapid onset, central P with hemodynamic sequelae. Retrosternal angina like SXS, RV ischemia. Syncope rare presentation, but indicates severely reduced hemodynamic reserve. Symptoms can develop over weeks. In PTS with pre-existing CHF or COPD, worsening dyspnea may indicate P. Clinical diagnosis of P. In summary, clinical signs, symptoms and routine tests do not allow for the exclusion or confirmation of acute P but may increase the index of its suspicion. Consider P in cases of unexplained tachycardia or syncope. Diagnosis probability assessment. Implicit clinical judgment is fairly accurate. Do you think this patient has a P? Validated prediction rules standardized clinical judgment. Wells. Geneva. Proportion with P. 65% 30-10%. Nonspecific. Chest X-ray usually abnormal, but nonspecific. Study of 2,322 patients with P. Cardiac enlargement, 27%. Normal, 24%. Pleural effusion, 23%. Elevated hemodiaphragm, 20%. Pulmonary artery enlargement, 19%. Atelectasis, 18%. Parenchymal pulmonary infiltrates, 17%. Chest radiographs in acute pulmonary embolism, results from the International Cooperative Pulmonary Embolism Registry. Chest July 2118 to 3338, 10.1378/chest.118.1.33. ECG usually nonspecific street/T waves changes and tachycardia. RV strain patterns suggest severe P. Inverted T waves V1 V4. QR and V1. Incomplete RVBB. S1 Q3 T3. S1 Q3 T3 and T wave changes. Other tests. Most patients with P have a normal pulse oximetry. AA gradient is insensitive and nonspecific. Diagnosis D-dimer VQ scan fibrin degradation product. ELISA tests are highly sensitive, greater than 95%. Nonspecific, tilde 40%, cancer, sepsis, inflammation increase D-dimer levels. VQ scan. Negative result excludes P safely in P unlikely patients, using clinical probability scores. A normal VQ scan excludes pulmonary embolism. Spiral CT direct visualization of emboli. Both parenchymal and mediastinal structures can be evaluated. Offers differential diagnosis in 2/3 of cases with a negative scan. But dye load at large radiation dose. Optimally used when incorporated into a validated diagnostic decision tree. Three-month VTE rate. 0.5%, all non-fatal. 1.3%. This algorithm allowed for a management decision in 98% of patients presenting with symptoms suggestive of P. Diagnosis summary history and physical examination. Then 1,2,3 approach. Clinical decision score. D-dimer test. Chest CT. 3. VQ scan remains a valid option for patients with contraindication to CT. Clinical management. After disembarking from a 10-hour airline flight, a 69-year-old man without past medical checks presents to the ER with acute dyspnea. BP is 120/80, baseline, and pulse is 120 bpm. Wells score equals 5, intermediate, D-dimer is positive. Spiral CT shows bilateral pulmonary emboli in greater than 50% of arterial tree. Congratulations! You've made the diagnosis. What's next? Question: for the hemodynamically stable patient, how can we differentiate between patients who are going to do well with anticoagulation alone versus those with worse prognosis who might benefit from more aggressive therapy? Risk stratification. Poor prognostic signs. Hypotension, not caused by arrhythmia, sepsis, or hypovolemia. SBP less than 90 mm Hg equals 53% 90-day all-cause mortality. SBP drop of 40 mm Hg for at least 15 minutes equals 15% in hospital mortality. Syncope equals bad. Shock equals really bad, poor prognosis, myocardial injury. Troponin levels correlate with in-hospital mortality and clinical course in P. Troponins do not necessarily mean me. Significantly increased mortality in patients with troponin level greater than 0.1 nanograms/ml, 0.R. equals 6. Normal troponin has very high NPV, 99 to 100%. Prognostic value of troponins in acute pulmonary embolism, a meta-analysis. Circulation 2007 116 to 427 to 433. Poor prognosis, myocardial dysfunction. Brain natriuretic peptide. Elevated levels related to worse outcomes. Low levels can identify patients with a good prognosis, NPV 94 to 100%. Prognostic role of brain natriuretic peptide in acute pulmonary embolism. Circulation 2003 107, 2545 to 2547. CT evidence of RV dysfunction. RV dilation. RV/LV short axis greater than 1 equals pulmonary hypertension. RV/LV short axis greater than 1.5 equals severe P. Leftward septal bowing. Transverse contrast enhanced CT scan shows maximum minor axis measurements of the right ventricle, A, and left ventricle, B. Figure 1. Transverse contrast enhanced CT scan shows maximum minor axis measurements of the right ventricle, A, and left ventricle, B. Note the flattening of the interventricular septum. RV/LV ratio equals 1.81. Vandermeer R.W. et al. Radiology 2005 235 to 798 to 803. Copyright 2005 by Radiological Society of North America. Echocardiograms before and after thrombolysis. Echocardiography RV dilation. Echocardiograms before and after thrombolysis. A 29-year-old woman presented with progressive shortness of breath. A computed tomographic scan of the chest showed a central saddle pulmonary embolism. An echocardiogram, panel A, showed an enlarged right ventricle and hypokinetic motion of the right ventricular free wall. After treatment without place, the right ventricular size and wall motion returned to normal. Panel B. Echocardiograms courtesy of Scott D. Solomon, MD, and Jose M. Rivero. Videos of these images are available with the full text of this article at http://www.nahum.org. Summary elements of P-risk stratification. Approved thrombolytic regimens for pulmonary embolism. Streptokinase 250 IU as a loading dose over 30 minutes, followed by 100 IU/H over 12 to 24 hours. Accelerated regimen, 1.5 million IU over 2 hours. Urakinase 4400 IU/kg as a loading dose over 10 minutes, followed by 4400 IU/kg/H over 12 to 24 hours. Accelerated regimen, 3 million IU over 2 hours. Catheter embolectomy and fragmentation. An alternative in high-risk P patients when thrombolysis is absolutely contraindicated or has failed. Cucker in Chest 2007 132 to 657 to 663. Heparin plus outplace compared with heparin alone in patients with submassive pulmonary embolism. Stavros Konstantinides, MD, Annette Geibel, MD, Gerhard Husel, PhD, Fritz Heinrich, MD, Wolfgang Kasper, MD and the Management Strategies and Prognosis of Pulmonary Embolism 3 trial investigators. In Engelgeme Med. Volume 347 15, 1143 to 1150. October 10, 2002. Conclusions. A combination of Alteplase, 100 mg given over a 2-hour period, and heparin prevented the need for escalation of treatment, with open-label Alteplase, catecholamine infusion, or mechanical ventilation, due to clinical deterioration more often than a combination of placebo and heparin. Clinical deterioration usually meant worsening symptoms, especially worsening respiratory failure. Bottom line: the decision to use thrombolytic therapy in the intermediate risk P group should be made on a case-by-case basis after carefully weighing the strength of the indication, the potential benefits, the contraindications, and potential adverse effects. Escape guidelines: non-high-risk P. Anticoagulation should be initiated without delay in patients with high or intermediate clinical probability of P while diagnostic workup is still ongoing. Use of LMWH or fonparinux is the recommended form of initial treatment for most patients with non-high-risk P. 3. In patients at high risk of bleeding and in those with severe renal dysfunction, unfractionated heparin within a target range of 1.5 to 2.5 times normal is a recommended form of initial treatment. Guidelines on the diagnosis and management of acute pulmonary embolism. European Heart Journal, 2008, 29, 2276 to 2315. Non-high-risk P. 4. Initial treatment with unfractionated heparin, LMWH or fonparinux should be continued for at least 5 days and may be replaced by vitamin K antagonists only after achieving target INR levels for at least 2 consecutive days. 5. Routine use of thrombolysis in non-high-risk P patients is not, yet, recommended, but it may be considered in selected patients with intermediate risk P, RV dysfunction, elevated troponin, BNP, and low bleeding risk. Guidelines on the diagnosis and management of acute pulmonary embolism. European Heart Journal, 2008, 29, 2276 to 2315. Treatment of acute pulmonary embolism. First unprovoked P. Rx for at least 3 to 6 months. Recurrent P or P and uncured cancer. Consider long-term anticoagulation if benefits risk. Agnelli G, Bicodny C. In Engel G. Med 2010 363 to 266 to 274. IVC filters may provide lifelong protection against P. Unclear effect on overall survival. Complications. DVT, 20%. Post-thrombotic syndrome, 40%. IVC thrombosis, 30%. Risk/benefit ratio difficult to determine since no RCT. Use when there are absolute contraindications to anticoagulation and a high risk of VTE recurrence. Consider in pregnant women with extensive thrombosis. Optimal duration of retrievable filters is unclear. Bard recovery venocava filter, Bard peripheral vascular, Tempe, Arizona, implanted in patient 2. Nicholson, W., et al. Argentine Med 2010 2010.316-5. Copyright restrictions may apply. The key is prevention. DVT prophylaxis in at-risk patients is quite effective. Just do it.